Good day, ladies and gentlemen. Thank you for the opportunity to present to you on the topic of access to radiotherapy and capacity building in Africa. My name is Dr. Henriette Burger, and I am the head of the Division of Radiation Oncology at Stellenbosch University in Cape Town, South Africa. These are my disclosures. I'd like to start by giving you some background on the African cancer landscape. The recent Lancet Oncology Commission report on cancer in sub-Saharan Africa estimated that both cancer incidence and cancer deaths in Africa would double in the next 20 years, with the biggest change occurring in East and West Africa. We also know that low and middle income countries carry 70% of the global cancer mortality burden. The likely drivers of this change in the cancer landscape include the high prevalence of virally driven cancers at up to 27% of all malignancies. And here we include liver cancer driven by hepatitis, cervical cancer with HPV, and Kaposi sarcoma driven by human herpes virus 8. We see that both patients with HIV disease and without have a longer life expectancy in sub-Saharan Africa. But we also see that HIV-associated malignancies are not showing a reduction in incidence. Africa is also well known for its environmental carcinogens, whether in the areas of agriculture, mining, or due to the increased uptake of a westernized lifestyle. And there's also evidence that there are some genetic predispositions that can modulate the clinical presentation of cancers. And here I'm referring to earlier and younger diagnosis of patients with breast cancer and also more aggressive prostate cancer being diagnosed in men of African descent. When looking at access to radiotherapy, a few demographic and macroeconomic concepts come into play. In the table on the left, we see that about 21% of the world's population live in Africa, of which nearly 15% live in sub-Saharan Africa. If we look at projected population growth over the next 3 decades, sub-Saharan Africa is the region showing the most growth, with most other regions experiencing stable or declining populations. Most of us are familiar with the World Bank classification of countries based on their gross national income per capita, or GNI per capita, into low income, low middle income, upper middle income, and high income countries, as shown in the map on the right. The map highlights the fact that Africa is home to the highest number of low and low middle income countries in the world. While it's understood that GNI per capita does not directly measure a country's level of development or the welfare of its residents, it has proven to be a useful, readily available indicator that is often closely correlated with other non-monetary measures of quality of life, such as life expectancy at birth, mortality rates of children, and enrollment rates in school. It is worth noting, however, that GNI per capita may be underestimated in lower income countries if a large portion of economic activity comes from informal or subsistence activities. Furthermore, GNI per capita does not, for example, reflect inequalities in the income distribution within countries. So it's safe to say that GNI per capita does not tell the whole story. If we delve deeper and look at global trends in poverty and financial inequality, we see that globally 8.5% of people are living under the international poverty line of $2.15 per person per day, as indicated by the black line in the middle of the graph. If we look at the yellow line slightly higher up, we see that in sub-Saharan Africa, this value rises to 37%. So while 15% of the world's population live in sub-Saharan Africa, it is home to 57% of the global poor. The graph on the left also shows that poverty rates have reduced worldwide since the 90s, with COVID interrupting this positive trend in 2020. Unfortunately, even though a number of countries have managed to move into higher World Bank brackets over time, the percentage of the population living below the poverty line has actually increased, especially in sub-Saharan Africa. Another classification system related to health outcomes is the Human Development Index, or HDI, which can be described as a summary measure of key dimensions of human development, including a long and healthy life, a good education, and a decent standard of living, where higher values indicate higher human development, as shown in this chart. One metric that is often used to compare the success of cancer control programs between countries and regions is the mortality to incidence ratio, or MIR. In these graphs produced by the WHO Global Cancer Repository, we see that the age-standardized incidence rate of cancer is actually low in Africa and in low to middle income countries. The mortality to incidence ratio is, however, much higher at 0.64 compared to the 0.3 ratio reported for high-income countries. A recent publication by Sharma et al., entitled Mapping Cancer in Africa, highlighted further aspects of the African cancer landscape. This included the significant economic and social impact that cancer is having in Africa due to its high incidence in younger populations, the people who are economically active or raising families. They also estimated that differences in HDI explain 75% of variations in cancer survival amongst countries. We see that a higher proportion of cancer patients are diagnosed with advanced cancer in Africa. Africa has approximately 24% of the global cancer burden, but has only 3% of health workers and spends less than 1% of world health expenditure. Furthermore, only 1 in 5 low and middle income countries have the necessary data to drive cancer policy. And lack of cancer registry data means health ministries do not have reliable estimates of radiotherapy needs to plan procurement and maintenance plans. This graph depicts the incidence and mortality rates of the 10 most common cancers in Africa and sub-Saharan Africa. It's interesting to see that the top 3, namely breast, prostate, and cervical cancer, have a slightly different incidence profile when North Africa is removed from the equation. Along with surgery, radiotherapy is the most important local treatment modality used in oncology. It is estimated that half of all cancer patients will need RT either for cure or palliation. The radiotherapy utilization rate expresses the percentage of cancer cases that will require radiotherapy as part of treatment. This rate often depends on the cancer site and stage. Here we see that RT is a definitive treatment option for 2 of the 3 most common cancers in Africa, namely prostate and cervical cancer, and that it is used in the neoadjuvant, adjuvant, or salvage setting for many others. And this includes EBRT and brachytherapy. It is also safe to say that nearly all cancers can benefit from radiotherapy in the palliative setting. The RT utilization rate for Africa is the highest worldwide at 54% due to late presentation and lack of surgical treatment options. It is therefore concerning that the African continent has the fewest resources available for radiotherapy globally. It is estimated that Africa delivers only 34% of the full RT need. Another challenge is the geographical distribution of RT machines within Africa. 82% of RT machines are located in Northern Africa and in South Africa. There are 99 brachytherapy facilities spread across 22 countries, but again, 75% are located in Northern and Southern Africa. And there are still more than 20 countries in Africa that have no RT facilities. It has been remarked that technology adoption across Africa has developed quite positively, with one exception: radiotherapy. When we talk about access to radiotherapy, I would like us to take a moment to consider the bigger picture, because ultimately our goal is to provide our patients with the right treatment at the right time, in the right place, by the right healthcare professional, with adequate support, and in line with universal health coverage at the right price. In order to achieve this, the radiotherapy team has to manage and optimize a number of direct and indirect resources or factors. Now, these factors may be unique to each country and maybe even to each hospital. They may even change over time, with different factors becoming more or less important. If we consider what the best treatment for our patient would be, we need to ask ourselves if we have access to radiotherapy machines, if we're able to offer 3D or IMRT, if we can offer the appropriate IGRT and patient-specific QA that the technique requires. Do we have access to 3D brachy? And do we use intracavitary applicators only, or do we have interstitial needles as well? On the indirect side, you will all acknowledge the importance of having proper radiology, pathology, planning, and chemotherapy services to support the radiotherapy delivery. When we talk about the timing of radiotherapy, we always aim to give the treatment in the therapeutic window. But this can mean different things in the curative and palliative setting. Unfortunately, this element has become a major barrier to RT access in many African countries, with some centers reporting waiting times of longer than a year for radiotherapy. Radiotherapy needs to be delivered in a safe environment, but also close to the patient's home. The reality is that radiotherapy centers are centralized in major cities, which makes it inaccessible to rural patients without easy access to transport. The multidisciplinary radiotherapy team is an essential element in access to radiotherapy. If any of the expertise of the direct or indirect team members are missing, access to good quality care diminishes. Under support services, I have included acute medical care for complications of radiotherapy, access to consumables, machine parts, and general services like air conditioning, power, water, and IT integration. But I also want to draw your attention to the soft side of support for radiotherapy. Making sure the patient is communicated with in an empathetic way to enable them to make treatment decisions, to deal with side effects, and to assure attendance is vitally important. There is a need for culturally appropriate radiotherapy services in Africa, and the more we can embrace this and approach it with innovative solutions, the better. And finally, the cost. Again, this is probably unique to each country and setting, but challenges with government subsidization, insurance coverage, cost to patients are common and regularly influence an individual patient's ability to access radiotherapy services. On a more practical level, one can consider the different factors that influence a site's capacity to deliver radiotherapy. On the left hand, we have demand metrics, and on the right, resource metrics. Radiotherapy demand per patient can be calculated using population density, cancer incidence rates, and RT utilization rates. We can even go one step further and estimate the number of fractions required by including what we know about the average number of fractions treated per course of radiotherapy, which in Africa is 16.4. On the resource side, access to RT machines can be quantified in terms of machines per cancer cases or machines per million people. The service capacity of these machines then depend on their operational hours per day, the number of work days per year, number of fractions deliverable per hour, and machine downtimes, whether this be for quality assurance or repairs. According to the IAEA's Directory of RT Centers, or DRAC, there are marked disparities in the distribution of radiotherapy machines in different regions of the world, both geographically and by GNI per capita. In these tables, we see that Western Europe has access to 7 RT machines per million people. This value is even higher for high-income countries. In Northern and Southern Africa, there are just over 1.1 machines per million people, while Central Africa has less than 0.1. In this IAEA analysis of RT resources in Africa by Elmore et al., we see a concerning trend for Southern Africa. Whilst the absolute number of RT machines has increased from 2012 to 2020 for all African regions, the number of machines per million people in Southern Africa has in fact decreased. This can most likely be ascribed to rapid population growth in this area. What is also concerning is that when we break down the ratio of machines per 1,000 cancer cases for South Africa, we see that patients attending private health services in South Africa have access to 4 machines per 100 cancer cases, whereas patients attending public health facilities have only 0.3. This estimate assumes equal incidence of cancer across the two groups and a 15% private healthcare utilization rate. Let's take a look at access to brachytherapy machines. The map on the left shows the incidence rates for cervical cancer in blue, with a clear concentration in West, Central, and Southern Africa. The map on the top right shows the distribution of brachytherapy services in orange. Again, service provision does not match the need. So how do we start to address these disparities in access to radiotherapy? A fundamental requirement for sustainable cancer management is a national cancer control plan. Such a plan should include strategies for prevention and screening, early diagnosis, staging, treatment, and palliative care. As radiation departments, our focus is mostly on the staging and treatment phases of the cancer journey, while leaving the prevention, screening, and early diagnosis elements to primary healthcare workers or surgeons. However, if these components of the NCCP are not effective, it results in more patients with advanced disease being referred for radiotherapy, where surgery alone might have sufficed if the cancer was diagnosed early. I would therefore like to assert that it is in our own interest as radiation departments to engage, at least in some way, in screening and early diagnosis campaigns to ensure that RT services are used appropriately. A good NCCP can ensure prioritization of RT access, allocation of resources for RT, they can develop guidelines for RT utilization and QA, and support regulation of staff, licenses, and monitoring. Unfortunately, the Mapping Cancer in Africa study showed that only 37% of countries in Africa have a cancer policy, strategy, or plan in place, and that only 65% have a cancer registry, and that screening is only available in the minority of countries. There are also many challenges with ensuring adequate numbers of trained staff to deliver radiotherapy in Africa. Across all professions, we see migration to private healthcare or even emigration for better working conditions or for market-related remuneration. In terms of radiation oncologists, only or less than 10 African countries have training programs. In South Africa, we see that 75% of graduates end up working in private practice. The IAEA recommends a ratio of 250 new patients per oncologist per year. A recent survey showed that in Africa, closer to 31% of oncologists see more than 500 new patients per year, whereas this statistic stands at 12% in other countries. Radiographers are sometimes asked to work shifts, work overtime. There is a need for specialist dosimetrists who are experts at dose planning and verification, but also those who are experts at delivering the radiotherapy in terms of setup verification and correct delivery. Medical physicists also have limited training programs available in Africa, and often they are forced to work after hours so as not to interfere with a clinical service delivery when they need to do maintenance and quality assurance. In terms of chemotherapy registered nurses, South Africa stopped training chemotherapy nurses for a 3-year period between 2019 and 2023. Luckily, that has been restarted again. Another specific issue is the availability of service engineers for the LINACs. And here, there is quite a difference in availability of vendor contracted service engineers versus access to in-house service engineers. We also know that there are very few radiobiologists remaining in African countries. And this is made even more difficult by the fact that professional registration is not formalized for radiobiologists. I have chosen the following model to help us explore opportunities for capacity building in radiotherapy. In the image on the left, you will see that capacity can be increased on 3 levels of a system. The individual level at the bottom can include patients or clients, healthcare professionals, and community stakeholders. The structural level refers to systems that are active on the hospital level, like clinical teams, medicines availability, laboratory services, IT infrastructure, and equipment. The third level looks at political and institutional elements like legislation, budget allocation, advocacy, and policy. Capacity building would then look different for each level. We see that on the highest level, support could be given to decision makers in establishing sustainable and equitable policies for cancer care. On the highest level, advice could be given on budgeting for acquisition and maintenance contracting for high-cost LINACs. On the hospital level, expertise could be applied to improve patient flow, regulate health products, monitor clinical performance data, and managing change. And on a personal level, the training of healthcare professionals can be supported and education programs for the public can be invested in. It is, however, very important to remember that capacity building is a long-term process, and that the following key principles should be the basis of any capacity building plan. Such a plan should be equitable. It should be accessible, whether that be based on finances, logistics, the local context, or its sustainability. It should strive to be excellent. It should be effective, safe, and always evidence-based. It should be efficient, and that means that waste should be reduced and that resources should be maximized through collaboration. It should also be responsive, which means that monitoring should be done, and if change is required, that it should be actively managed. And finally, a capacity building plan should be person-centered, because this is required to ensure buy-in from all stakeholders. Capacity building requires investment. So what are the modalities that can be invested to strengthen radiotherapy services? Investment can take the form of knowledge or ideas, skills, funds, and even equipment, technology, and infrastructure. For professional experts, it can take the form of time effort. Investment can also be made by imparting attitudes of innovation, growth, and resilience. It can also be made in the form of incentives that could motivate the implementation of effective radiotherapy utilization programs. We know that radiotherapy treatment requires substantial initial funding, large-scale and sustainable financing streams, a body of highly trained medical professionals, and a robust safety, security, and quality assurance framework. These graphs show the additional investment required in RT services to meet the full service requirements in different regions of the world. For Africa, this is close to 200% of current investment across equipment and staffing. However, if we look at the investment need projected for Africa in the middle graph, in blue, we see that the absolute investment value is not exorbitant when compared to other regions. Atun and colleagues reported that operating costs in low-income to upper-middle-income countries range from 60 to 86 US dollars per fraction, in comparison to 235 US dollars per fraction in the high-income setting, guaranteeing a higher return on investment in radiotherapy in low-income countries than in wealthier nations. So what is already being done to increase radiotherapy capacity in Africa? In terms of service delivery strategies, many countries have made changes to the way in which RT is delivered to leverage the available resources. One example of this is hypofractionation, through which overall treatment time is reduced by using larger fractional doses per day. This, in turn, allows higher patient turnover on machines and relieves some of the burden on patients to attend for multiple weeks. Many centers in Africa have also adopted advanced radiotherapy techniques through the acquisition of machines with IMRT and VMAT capabilities. This increases patient throughput on machines, ensures the safety of hypofractionation, and can decrease radiotherapy toxicity. Remote radiotherapy planning systems have been utilized in some areas of Africa to give more centers access to skilled dosimetrists. Artificial intelligence and machine learning has also been increasingly employed to reduce the time burden of contouring and especially organs at risk. Beyond service delivery strategies, we have seen significant internal and external investment in radiotherapy equipment, technology, and infrastructure across Africa over the past couple of decades. Since the COVID pandemic, access to distance learning and training options have expanded significantly. RT experts across the world have pooled resources to create shared online teaching platforms, tumor boards where difficult cases can be discussed, and online meetings where radiotherapy contours or plans can be reviewed. Major investments have also been made to strengthen Africa-centered research through study group networks and inter-university partnerships. The past few decades have seen major advances in our ability to deliver increasingly conformal radiotherapy. Moving from 2D to 3D and now IMRT or VMAT radiotherapy techniques has allowed us to escalate dose to the cancer target while at the same time limiting dose to adjacent normal tissues. To obtain these gains in cancer control and reduction in side effects, the radiotherapy team, however, needs to increase their attention and effort with immobilization, imaging, delineation, planning, plan verification, and verification of treatment delivery. And this requires additional training, time, and effort to ensure safe and effective RT delivery. The concept of hypofractionation arose from the radiobiological differences in the response of tumor versus normal tissue to radiotherapy. Using daily RT fractions of greater than 2 gray proved to result in better cancer control and shorter treatment times, especially in cancers with low alpha-beta ratios like prostate and breast cancer. This was seen as an attractive solution for increasing access to radiotherapy in low-middle income countries, where shorter treatment courses could lead to higher throughput of patients. Over the past few years, we have seen evidence emerge for the safe utilization of hypofractionation in cancers with lower alpha-beta ratios like prostate and breast cancer, but also in those traditionally considered to have high alpha-beta ratios. Here I have indicated the seminal trials for prostate, breast, and head and neck cancer. So what can be gained from implementing advanced RT techniques? We can achieve similar or even reduced long-term RT toxicity. There is evidence for improved cancer control outcomes in some studies and sites, but the main advantage is that it reduces overall treatment fractions, as in hypofractionation, or it reduces the time to deliver a fraction, as we see in field-in-field techniques and VMAT. But there is no denying that these benefits go hand in hand with increased planning complexity and QA requirements. Any center that plans to implement advanced techniques must be aware of the additional requirements it involves for delineation, planning, image guidance, and quality assurance. Often, this requires the establishment of new processes and workflows, increased potential for error, and steep learning curves, all things that could be very unnerving and destabilizing for radiotherapy teams. Active change management is therefore required to guide staff through the implementation process. To ensure accurate volume delineation, oncologists have to become comfortable with image fusion and correct margin selection. Dosimetrists and clinicians have to build confidence in optimizing and evaluating VMAT or IMRT plans. Radiotherapists and clinicians have to invest more time into position verification with every fraction, in reading CBCTs and using fiducial markers. And perhaps the most important of all is the added input required from medical physicists, because patient-specific QA is required for each plan. Such an implementation plan therefore requires capital investment, hands-on training, active change management, and continued technical and clinical support for at least the first year of implementation. The responsibility for capacity building in healthcare and in cancer care ultimately lies with national health ministries. The reality, however, in many African countries is that national cancer control programs are not seen as a top priority when it comes to policy making and funding, when there are competing health needs like infectious diseases, violence and trauma, and maternal and child health. In this environment, we have therefore seen professional associations and non-governmental organizations step up in many African countries to advocate for higher standards and equitable access in cancer care. We also see that the African Union and NEPAD support cancer control efforts across Africa. In the next few slides, I would like to highlight a few of the successful capacity building programs and organizations that are currently active in Africa. This is in no way an exhaustive list, but should give you an idea of the scope of projects that you might want to get involved with if you are not already a collaborator. The African Organization for Research and Training in Cancer, or AORTIC, has been a leading force in building capacity for cancer advocacy, research and training in Africa. Their biannual conference, held in Africa, provides training updates and promotes research led by local medical professionals working with global collaborative teams to drive the African research agenda. The World Health Organization has acknowledged the growing burden of cancer deaths in low-middle income countries for some time now, and has been a leader in providing knowledge, guidance, and support to countries who want to develop cancer control plans. The WHO is also home to the International Agency for Research on Cancer, or IARC, whose Global Cancer Observatory provides clinicians, researchers, and policymakers with up-to-date information on the cancer disease burden in Africa. Specific research projects that countries can collaborate in are ongoing in the fields of breast cancer and bladder cancer, just to name a few. The International Atomic Energy Association's Rays of Hope project strives to reduce cancer deaths worldwide by increasing access to safe and secure radiotherapy and diagnostic imaging. They aim to support member states in implementing cancer control plans by strengthening radiation safety legislation, doing RT needs assessments, leveraging funding, expanding infrastructure, and providing support with quality control, training, and procurement of equipment. The IAEA is in fact the leading funder of formal training for radiation oncology fellows from African countries. Through its Rays of Hope program, the IAEA has established 9 anchor centers globally to act as regional experts in training, research, QA, and development of locally relevant guidelines on medical uses of radiation and imaging. In Africa, we have 3 Rays of Hope anchor centers, with 2 located in North Africa and 1 in Pretoria, South Africa. Rays of Hope would like to drive innovation in research, data management, and training through partnerships with member countries and industry stakeholders. An example of an innovative training solution is shown here, where a virtual reality brachytherapy training system is used to train doctors who do not yet have operational RT delivery systems in their institutions. Through the International Cancer Control Partnership, a program of the UICC, most of the world's leading organizations engaged in cancer control planning efforts have managed to create synergies to maximize collective resources and efforts to support the development, implementation, and evaluation of national cancer control plans. This is yet another resource for low-middle income countries to access support for developing their own cancer control plans, whether it be technical assistance or links to capacity building opportunities. The International Cancer Expert Corps has been working with CERN and leading universities and institutions in the UK to advance the design of an affordable and robust, yet technically sophisticated, linear accelerator-based radiation therapy treatment system in sub-Saharan Africa through Project Stella, smart technology to extend lives with linear accelerators. Project Stella has brought together international and African experts in the field of medical physics, radiation oncology, engineering, radiobiology, IT, and health systems research to develop RT machines specifically designed to meet the needs of sub-Saharan African hospitals, whether this be high rates of patient throughput, limited access to maintenance and repairs, or extreme weather conditions like heat, humidity, or dust storms. Formal or accredited training programs in radiotherapy techniques for oncologists and medical physicists are offered by internationally recognized organizations like ESTRO, IOMP, ASTRO, and the Global Oncology University. Many of these programs now incorporate online or part-time participation and self-study, which makes it infinitely more accessible to radiation professionals from LMICs and those who work in facilities with low staff numbers and high patient loads. The Global Access to Cancer Care Foundation, or GACCF, has made it their mission to empower clinicians in low-middle income countries to independently provide effective oncology services in their communities by supporting comprehensive clinical training programs. The ultimate goal being to create a core base of local experts that can strengthen service delivery and disseminate RT knowledge and skills in their regions. In Cape Town, South Africa, GACCF has developed the Access to Care training program with the University of Cape Town, the Cape Peninsula University of Technology, and Varian Medical Systems as their main partners. This project offers online and in-person radiotherapy training programs on transitioning from 2D to 3D radiotherapy and implementation of advanced RT techniques. Another initiative of GACCF, in collaboration with Radiating Hope, is the biannual International Greater Horn Oncology Symposium that brings together radiation oncology experts from Europe and the US, industry representatives, and radiation oncologists, medical physicists, and radiation therapists from Africa. The symposium, that is hosted in Africa, has successfully sparked collaborations among institutions in North America or Europe and low-middle income countries represented at the meeting, and amongst African nations, to help create self-sustaining collaborations in developing local cancer care. At the 2024 meeting in Cape Town, Access to Care Cape Town joined forces with the visiting experts to offer a contouring workshop to African oncology trainees and specialists. The opportunities to collaborate in research initiatives with a specific focus on cancer care in Africa has also seen growth over the past few years. It is immensely encouraging to see that topics relevant to the African setting are being addressed, like adoption of hypofractionation, HIV-related cancer, screening and early diagnosis, establishment of cancer registries, and childhood cancers. The fact that the research agenda is more aligned with African health challenges gives local centers an advantage over others when it comes to recruitment. In my experience, the process of drafting and registering a research protocol, opening a site for recruitment, and managing a study has led to major expansions in capacity at my center, whether it be knowledge, skills, or infrastructure. So I would like to encourage other centers to try to do the same. I would like to conclude by giving my perspective on opportunities for future capacity building that I would like to see implemented across Africa. In the arena of technology advancement, we should all be advocating for the safe implementation of advanced RT techniques, including 3D brachytherapy, hypofractionation, IGRT, and IMRT or VMAT. My own institution in Cape Town is currently involved in the Hypo Africa project, evaluating the feasibility of hypofractionation in prostate, breast, and soon gynecological cancers in Africa. Through Aortic, my fellows and consultants are participating in the Brachythera online course that equips centers to implement 3D adapted brachytherapy based on CT image guidance. We should all be looking into using artificial intelligence and machine learning in some way to reduce planning time and free up staff. Here, our department's physicists and oncologists are involved in the archery study with UCT, University College London, and the MD Anderson team to investigate the feasibility of a radiation planning assistant system. As mentioned before, and relevant to this audience, I cannot emphasize the importance of building capacity in medical physics enough. With the implementation of advanced RT techniques, the role of the medical physicist in QA and machine maintenance becomes exponentially bigger. Training programs should be expanded and resources should be pooled in regions where expertise are lacking. Another area for expansion is establishing local manufacturing or service hubs for radiotherapy machines and parts. This is a way to shorten downtimes and enable higher patient throughput. Since the COVID pandemic, IT solutions for telemedicine have been widely implemented to enable contact between clinicians and patients. These platforms can also be used to enable peer review of radiotherapy plans and remote consultation with experts across the world. Remote RT planning systems can again allow pooling of resources to give remote sites access to expertise. Research on the effectiveness of radiotherapy in Africa and the patient experience is needed that can translate into context-appropriate practice guidelines. Regional cooperation on aspects like funding and procurement, sharing of expertise, and training opportunities and research should be prioritized, and we should all be sharing the lessons learned to leverage developments. In countries where there are disparities between publicly and privately funded cancer care, the models for public-private partnerships need to be revisited urgently. And when I think about international collaboration opportunities, it helps to consider what we as African countries have to offer before we think about what we need. We give industry the opportunity for market expansion. We have a unique cancer profile with virally driven cancers. We have more advanced cancers, and we serve populations with vast cultural diversity. Most big cancer centers have established IRB support, and we have cost-effective labor, and our patients are generally keen to volunteer for research studies. But we do need support with obtaining funding, access to specialized expertise, support with data management, and better ways to track patient outcomes. Investing in radiotherapy capacity building should be a priority for all of us. I hope that with my presentation, I have given you a better understanding of the scope and opportunities for improving access to radiotherapy for the patients of Africa, and that you will be encouraged to apply your expertise to make a difference, whether it be big or small. Thank you for your attention.